Good afternoon, everyone. Thank you for joining us for our Thursday educational webinar. I'm Melinda Bikini, Director of Advocacy with the Cholangiocarcinoma Foundation. And today I am pleased to bring to you, we are going to have a presentation from Tempus, and we are joined by Calvin Chow. He is the Senior Vice President of Medical Affairs at Tempus Labs Incorporated. He manages a team of medical and scientific professionals responsible for medical oncology research collaborations, education, and physician support services. Dr. Chow has over 20 years experience in oncology, precision diagnostics, and pharmaceutical medical affairs experience, and 10 years experience as a clinician and healthcare system leader in internal medicine. He's going to go through his presentation, and we'll have plenty of time for questions and answers at the end. So if you have questions as we go through the presentation, feel free to write them in the chat box or the Q&A box, and we will get them answered at the end. And I will turn it over to you, Dr. Chow. Thank you.
Thank you very much, Melinda, and good afternoon to you all. Thank you for your time. I'm going to be presenting on precision medicine in cholangiocarcinoma, how comprehensive molecular profiling identifies personalized treatment options for patients. This has been actually a very eventful set of years recently where a number of drugs have been approved for this disease. And I'd like to go through some of the evidence behind those approvals and the importance of molecular profiling specifically in finding the right patients to treat with each of these different therapies. So as an outline of my presentation, I'll start with a case study, which I think nicely cues up this topic and illustrates really how challenging of a disease this is, but at the same time, what hope there is in the fact that we now have the emergence of some new potential treatment options. And then I'll get into some of the specifics around some of the targeted therapies, as well as the specific gene alterations that are found by molecular profiling that are important to identify the right treatments for the right patients. I'll talk a little bit about clinical utility evidence. What I mean by that is that, what is the actual performance of our testing and treatment strategies overall for all patients with this disease? And are there any outcomes that we can point to that, again, provide even further hope in the years that come, but what has been generated so far on a large scale. And then finally, I'll talk a little bit about some of the cancer test offerings that Tempus Labs provides, specifically the value of comprehensive testing, having the opportunities to test not only tumor tissue, but also blood-based circulating tumor DNA profiling, which sometimes one needs that. And we'll talk a little bit about some of the other nuances to the tests that we have. And then I'll end up with just a brief mention of the importance of clinical trial matching, another important aspect of options for patients, and how the data platform that Tempus has can help enable some of this matching. Let's start off with a very macro view of this space. This era of next generation sequencing, that's what NGS stands for. I really found interest in two papers that were recently published this year, which profile really kind of a recent history of next generation sequencing informed therapies. And on the left side, you can see that a number of different solid tumor types are represented here. This is the aggregate of many, many different diseases. But overall, you can see that since 2006 up to 2020, that this has really grown, that the percentage of US cancer patients receiving and being responsive to a genomically informed therapy that has grown. And certainly if you look at the years 2017 and onwards, if anything, we're starting to see an acceleration of this strategy working. In other words, being informed by looking at the molecular profile of a tumor, seeing what is the underlying biology, and then asking what is the best drug to target that particular gene alteration or molecular alteration. That's really, I think, hitting a potential inflection point, I think, a separate paper on the right actually came up with the same observation. And if anything, we're really pleased to see this very marked increase in the rate of new biomarkers being discovered, new drugs that are being developed for those biomarkers, new clinical contexts, and new infrastructures, such as the ones that I'm going to share with you from Tempus, that are really helping to enable some of these getting the right treatments to the right patients. So I'll start off with this case study, and I was very interested to see that just a couple of months ago in the New England Journal of Medicine, August 2021, one of the issues highlighted a case study. These are really interesting case studies that, in fact, every medical student, every physician in training is very familiar with. Typically, the New England Journal highlights cases that are very timely and really carry some very educational points of interest that highlight an ongoing aspect of what's going on in that disease. So I was very intrigued to see a case on cholangiocarcinoma. This is a 34-year-old woman who presented, as you can see on the far left, that she was diagnosed with what was initially a resectable cholangiocarcinoma. It was a single lesion in the right lobe of the liver. When found early like this, these patients can undergo surgical resection with curative intent. And indeed, that's what happened with this patient. She actually received a right hepatectomy and followed that with some adjuvant chemotherapy, which is the standard of care, with gemcitabine and cisplatin. Well, the patient actually was then followed in a surveillance program. And for about 12 months, she did fine with no further disease. But then after that 12-month period, unfortunately developed a new lesion, this time in the left lobe of the liver, 1.4 centimeters. At that time, she underwent restarting the gemcitabine cisplatin chemotherapy, but unfortunately developed a sensitivity reaction. And so because this was still a single lesion, the physicians treated her with a microwave ablation therapy with some response, evidence of response. 3 months later, in a further surveillance, she unfortunately developed 2 new lesions in the left lobe of the liver. And that's when she underwent a second surgery, a left partial hepatectomy. Then after that surgery, she had further surveillance for another 5 months, and unfortunately then developed multiple lesions, this time not only in the liver, but also in the lungs. So this is where this patient now underwent molecular testing. So this molecular testing, interestingly, found an FGFR2 gene fusion. This is actually a very important marker now, and we now have some approved drugs called FGFR inhibitors that target this gene fusion. But at the time of this case, this patient was found with this finding before any approved therapies were on the market. And so she actually then underwent enrollment into a clinical trial, a phase 1 clinical trial for futibatinib. This is one of several FGFR inhibitors that are in development. And so she went on that drug. And interestingly, after 6 weeks of taking this drug, she actually showed on scan that there were multiple lesions that responded or resolved. And that's really quite a dramatic response in just a short amount of time for someone who actually has, kind of continued emergence of different metastases appear. It was very encouraging to see this kind of response. And in fact, this therapy, of course, it was, in a drug trial, actually controlled her tumor burden for 7.2 months. And at the end of that time period, of course, in the surveillance, she did eventually show further signs of recurrence and progression, where CT scans showed evidence of mixed response, some new enlarging lesions, but in some cases, some of the original lesions had resolved. I think that's to suggest how complex cancer really is, that, sometimes there is a particular tumor biology for which there is a drug, And those particular clones potentially can be eliminated, but unfortunately, the tumor can evolve, and there might be other clones that are resistant to that particular therapy or refractory, and they then become the new enlarging lesions. And at this time point, the patient, really had no further options, and she enrolled into a hospice program for comfort care. But I want to use this kind of framework to kind of illustrate, how complex of a disease, how challenging of a disease cholangiocarcinoma really is. And I think it's in that framework to really appreciate, what are some of the advances that are being made in systemic therapies. So for systemic therapy options prior to the emergence of any targeted therapies that are now available today, we only need to look back to prior to 2018, not so long ago, when basically we know that the standard of care in the first line is chemotherapy with gemcitabine and cisplatin. But after that, the standard of care was simply active symptom control, because there really was no other therapy at the time that had any evidence. This study, though, was actually a study of a different chemotherapy called FOLFOX, which is a 5-FU fluorouracil plus oxaliplatin chemotherapy regimen. And this was a positive trial that showed that when patients were randomized to the FOLFOX chemotherapy with active symptom control versus active symptom control alone, indeed, there was a benefit in improving overall survival. As you can see on the right, those patients that received the FOLFOX had a slightly longer overall survival than those that received active symptom control alone. But the difference here was really about 1 month, and one might consider that 1 month overall survival benefit needs to be counterbalanced with what are the toxicities of receiving this therapy with FOLFOX. And you can see that it's hard to see, I apologize for the small print, but when you look at this graphical representation of the various side effects that are grade 3 to grade 5, grade 3 means it really impacts the patient's activities of daily living. And so you can see that down at the bottom of this chart, some of the significant chemotherapy related adverse events include things like infections, fatigue or lethargy, neutropenia, which is a drop in the white blood cell count. So, these are some of the costs that are associated with taking chemotherapy. And, some of the expert oncologists that commented indicated that, it's not a, for a 1 month improvement, one really needs to think about, is this the right thing to do or not? And so I think there was some controversy as to whether or not, this was that much of an advance in treatment. So I'm going to get into the targeted therapies now and talk about some of the important gene alterations that are important in this disease. But really, when we talk about cholangiocarcinoma or biliary tract cancers, we have to think about what is the anatomic site of the cancer, because they behave differently. They have different molecular profiles, and they have different clinical outcomes that need to be understood. So on the left, you see a picture of the biliary tree, the biliary system, and the 3 circles actually that are pointed to include the intrahepatic cholangiocarcinoma. That's when the tumor is really within the substance of the liver itself. The biliary tree actually has ducts that are within the liver itself, and when the cancer arises from the lining of the biliary system within the liver, we call that intrahepatic. And then if the cancer affects the biliary system outside of the liver itself, we call that extrahepatic. And that's when it's in some of the larger ducts that feed into the finer biliary duct pathways. And then the gallbladder is also a part of the biliary system. And if the cancer affects that organ, and that was a gallbladder carcinoma. So here you have the 3 types of biliary cancers. And you'll notice that when we look at the rate of finding various gene alterations, they are different, right, across each of these three different types of cholangiocarcinoma or biliary tract cancers. And these ones that I highlighted in red are the ones where I'm going to actually talk through some of the new therapies that are available or are in development. And so you'll notice that the intrahepatic cholangiocarcinomas actually have quite a few of these findings where the gene alterations that are potentially targetable can be found. So this is just a kind of a big picture look at how often do we find these gene alterations that are targetable. And you'll notice that in the advanced metastatic setting for patients who have these different gene alterations in the second-line setting or beyond, this is from the literature, kind of gathered from different sources, where we see that, you know, these are the targets of interest from IDH1, FGFR2, NTRK, which is actually fairly infrequent, and BRAF V600E. You'll see that there are different frequencies of finding these different alterations, and they are now associated with these FDA-approved drugs listed to the right. I think what's notable is that in cholangiocarcinoma, especially for patients who have intrahepatic disease, that now we're actually approaching a point where a very sizable population is likely to have at least one of these gene alterations and would therefore have some potential therapeutic implications. So I'll start to go through these one by one. The first one that I'll talk about is actually the most recent approval. The ivosidenib drug was approved by the FDA just a couple of months ago. And this is a phase 3 trial called Clarity, with IDH actually in the name there spelled out. This was a drug, ivosidenib versus placebo clinical trial in patients who were previously treated. So you'll notice to the left, the patients included in this study were not in the first line setting. So first line is still chemotherapy, but patients would have had to receive 1 to 2 prior therapies, at least one with gemcitabine or 5-FU containing regimens. And they all had to have this IDH1 mutation found on next generation sequencing. So that means they had to have that molecular test found to have IDH1 mutation. They had to have already completed at least one course of a chemotherapy regimen and then progressed on that. These patients are randomized in a 2-to-1 fashion to receive the drug ivosidenib, 500 milligrams orally every day in 28-day cycles. There were 126 patients on that arm, and compared to placebo, 61 patients that received placebo. Part of the study design allowed patients to cross over. In other words, if the patients had placebo and they had disease progression on placebo, they were then allowed to take the study drug. So what you see here on the right is the overall progression-free survival results. Progression-free survival is actually a typical key endpoint looked at in these clinical trials. And you'll notice that the ivosidenib produced a median progression-free survival of 2.7 months compared to placebo 1.4 months. So it's you know, kind of a twofold difference. And importantly, when you look at what percentage of patients are progression-free at 6 months and at 12 months, you'll see that for the ivosidenib, about a third of the patients are progression-free at 6 months and 22% at 12 months. Whereas placebo, I think there were no patients that actually had progression-free at that time period. The disease control rate is DCR. That's those that have partial response and stable disease. Stable disease is actually very important in cholangiocarcinoma because it just means that, you know, although your tumor doesn't necessarily shrink, which is what partial response means, stable disease means that, you know, you're actually having no evidence that the disease is actually getting bigger or progressing. So it does suggest that there is a control of that disease. And so having 53% of the patients having control of the disease with the study drug was very encouraging. compared to 28% for placebo. So, it's always good to also balance the treatments and their potential benefits with potential side effects. And so, as we see here, the ivosidenib in the middle column is the patients that were assigned in the in the trial. But then notice that there's a first column that has the asterisk, meaning that because patients were also able to cross over, they add all the patients into this first group. And notice that when we talk about adverse events, even patients who got placebo also suffer adverse events too, because obviously people are ill with the disease, and that disease will carry a lot of these side effects as well. But of course, the ivosidenib produced higher rates of these symptoms such as nausea, diarrhea, fatigue, abdominal pain, etc. So I think you can take a look and see that certainly there is a rate of side effects associated with the therapy, and that is something that's always got to be looked at as one considers treatment with the drug. So that's the IDH1 ivosidenib data that just was recently approved. Another class of agents is actually now there are two drugs that are approved, the infigratinib and the pemigatinib in the first two columns here. The others are still in development, but the data is underway. The FGFR inhibitors are indicated in FGFR2 fusion positive cholangiocarcinomas. And so I'm going to spend most of my time speaking about the first two drugs. The futibatinib, you may recall, is the drug that was featured on that case study. And then the other two are still, I think, still not yet approved and still being developed. So the FIGHT 202 study was the study that actually resulted in the pemigatinib being ultimately approved for FGFR2 fusion findings in cholangiocarcinoma. It was a phase 2 study, meaning it was actually a study that was looking to generate evidence of disease response, and it was not randomized to a placebo. It was just basically a single arm, all patients getting the same therapy. Sometimes the FDA does approve drugs, and I think that's wonderful, because then when they see that there's a fairly sizable benefit through a lot of patients showing response, or having a significant median progression-free survival or overall survival, that in comparison to patients who with prior standards of care, if that represents a sizable potential improvement, I think that the FDA makes these judgments, and certainly for pemigatinib, that is also another approved drug that was recently approved. So here you see that the patients, again, were ones that had to have the next generation sequencing document that they were FGFR2 mutated, and they progressed on one or more prior lines of a systemic therapy, typically chemotherapy. And cohort A is the majority of the patients here. What the drug company was doing was looking at patients that had the FGFR2 fusions in cohort A. Cohort B had other kinds of FGFR genetic alterations. There's FGFR1 and 3 and 4. So there's different ones, and there's the possibility that some of these drugs may also be good for FGFR3 or other kinds of gene alterations, but it's not shown here in this trial. But that's why they want to get a signal there. And then for the cohort C, they didn't have any of these alterations in FGFR, only 18 patients there. Right now, all we have are the data in cohort A, and you can see here to the right, these are the patients' overall response results. The way we read these graphs, we often call this a waterfall plot, because when you see here is the point 0, and you'll see that the y-axis shows negative numbers, meaning if you have a bar that points in the negative direction, it's representing a decrease in size of the tumor, all the way up to 100%, which means a complete disappearance of the tumor. If the bar goes upwards, it means that the patient's actually having a larger progressive disease, a larger tumor. And so you'll see that what this kind of visually tells us is that, firstly, there's a lot of patients who show decrease in size of the tumor. And in fact, if we want to classify these as complete responses in blue, partial responses in red, and stable disease in green, a lot of patients are actually experiencing some form of either response or a stabilization of the disease, which is very good. So the overall response rate here is 36%, and the disease control rate is 82%. So that's really quite good for these patients who have already progressed on chemotherapy. The FGFR2 fusion group, the cohort A, had a median progression-free survival of 6.9 months, and the median overall survival 21.1 months. So, that is really, a year and 9 months. And I think that's really quite an advance for these patients who, again, would have otherwise had no particular options. So again, the safety features and the side effects are profiled here. Here we are actually showing the grade 1 and grade 2, which are more minor side effects, and the grade 3, which is more effects that affect the patient's activities of daily living. And you can see many of the different adverse events that happened. But not to a very large degree. I think a lot of these with grade 3 or more, I mean, they tend to be in the low single digits and percentage numbers. And so overall, this is a fairly reasonable therapy in terms of what the patient can be benefiting from and having to endure. Now, there is this hyperphosphatemia that happens a lot with these agents, and that's something that is true for all of the drugs in this class thus far, where the phosphate levels go up, and it's something that the physician needs to be attentive to manage. These are grade 1 and 2 types of symptoms, and need to be simply tracked and managed. Another drug that it's an FGFR2 fusion directed therapy. The trial here featured infigratinib, a phase 2 trial, a very similar kind of study design, where you can see, again, patients here who were enrolled include those who are progressed or intolerant to gemcitabine-based chemotherapy. They had to have the FGFR gene fusions or rearrangements, and they all received, in this case, a single arm monotherapy with infigratinib until they progressed. And here you can see the similar kind of waterfall plot where a lot of patients are showing either a response, complete or partial response in green, or at least stable disease, and it's only a very small minority that actually progressed. And then you can see here the progression-free survival, median 7.3 months, and overall survival median 12.2 months. So these were also similar to the trial we just saw earlier, and you can see this similar kinds of side effects, the hyperphosphatemia, and then some of the other side effects that were also noted with this drug. So I'm going to switch gears here and talk about a different molecular target now, another gene alteration called BRAF V600E. This is a very specific gene alteration that frankly has approved therapies in other cancer types. And here we're looking at a trial that's called a basket trial. A basket trial is actually a trial where patients may enroll if they have this gene variant with any kind of cancer or multiple types of cancers. And of course, this trial included the cholangiocarcinoma patients. And so what we're looking at here are the results of the patients who had cholangiocarcinoma. And this is called the ROAR trial, Rare Oncology Agnostic Research Basket Trial. The treatment was with a combination of dabrafenib and trametinib for this BRAF V600E mutation. And so here we see in this phase 2 study, there were 43 patients enrolled who had metastatic, locally advanced, or recurrent biliary tract cancer with previous systemic treatment. So once again, we're talking about in the second line setting or beyond. Here you see that, again, the waterfall plot shows a sizable population who have either a partial response or at least stable disease. This middle plot is actually called the swimmer's plot, where each of these bars represent the progress of the patient and the time since starting the therapy. And so you can kind of get an appreciation for how long some of these patients are able to stay on therapy. And you can see by the indications here whether they had partial response or stable disease. And then you can see again on the right, the median progression-free survival was 9 months, and the median overall survival 14 months. Again, for patients with BRAF V600E treated with the combination of these two drugs, dabrafenib and trametinib. Another marker that's important is called HER2. This is also called ERBB2. And this is a marker that's very, very well known in breast cancer. But now in recent years, there have been a number of other tumor types where patients who have HER2 amplification are identified and potentially treatable with some of the anti-HER2 therapies. So in this case, we're talking about a basket trial called My Pathway for patients who have refractory HER2 positive tumors. There were 39 patients with biliary tract cancer treated with the combination of pertuzumab and trastuzumab. These are anti-HER2 therapies. And you can see here that the waterfall plot here again shows a good proportion of the patients with partial response or at least stable disease. The overall disease control rate 51%. The median progression-free survival was 4 months, and the median overall survival 10.9 months. So this is also some encouraging data for patients who have the HER2 positive finding on gene testing. So overall, there's a large a number of patients now to look for with these various different gene alterations. But how do patients overall fare? What's the overall sort of clinical performance of this strategy of using a molecular test to find these gene alterations, and if you find the specific alteration, to use the particular therapy? This is actually not a new trial. This was actually a trial back in 2017 was the publication. So I suspect that even back then, many of these agents that are approved today were still experimental, and we're really talking about a time that maybe didn't have as many treatment options as people do today. But it is a trial called Moscato 1. You can see that was 1,035 patients, and out of these, biliary tract cancer patients numbered 43. So this was actually a trial that for many different cancer types, they're just looking at, what is the sort of success rate, if you will, of finding gene alterations and then treating these patients. So 40 out of the 43 patients, you'll notice that 9 patients, 4 failed a biopsy, and 5 actually didn't have enough cancer cells in the sample. So 9 patients couldn't get a test performed, next generation sequencing test. Now I'll say that in that case today, we would also suggest that a liquid biopsy can be another option. So doing a blood test, if you can't get tissue or the tissue fails, it may be important to actually do a circulating tumor DNA analysis using a blood test. It's not always possible to find the circulating tumor DNA there, but it is something that's an option. So anyway, patients then who are fit for analysis numbered 34 patients. And you can see that out of the 34 patients that went to be analyzed, 3 actually had no alteration, 8 had no druggable alteration. So that removes another 11 patients, but 23 patients remain, which represents really a 68% rate of finding a druggable molecular alteration. So that actually is about a 2 out of 3 chance that patients who are fit for analysis, who can actually submit a tissue sample and have the next generation sequencing performed, 2 out of 3 patients potentially have some kind of alteration that can be addressed by a therapy. And in this study, 18 of the 23 patients were actually treated. How did they do? You can see on the right, the patients who were actually receiving these targeted treatments are in the red curve, and the patients who did not receive such therapy are in the black curve. And you can see that overall, there certainly is an improvement in the overall survival, or probability of survival is better for patients who actually have a targeted gene alteration to target and to receive that therapy is really the optimal way to manage patients if they have the right tumor biology. So I didn't mention one other important new development in recent years, and that is the development that's going on in immunotherapy. So immunotherapy is a different kind of strategy to treat patients using, really harnessing the patient's own immune system. The immune system can actually also fight cancer cells because the cancer cells are seen as something foreign. And in fact, this drug pembrolizumab is one of such therapies. Pembrolizumab is the one therapy that actually got FDA approval if patients have either a high microsatellite instability, which is kind of a molecular finding, again, available through these tests, or a high tumor mutational burden. Again, that's another measurement available through tests like the Tempus XT assay. So if one has a finding of either microsatellite instability that's high or tumor mutational burden high across any cancer type, according to this Keynote 158 trial, here are the results that were shown. And here in this one table, they actually call out the patients with cholangiocarcinoma. And you can see that there were 22 patients there. 2 had complete response, 7 had partial response. The overall response rate was nearly 41%. The median progression-free survival, 4.2 months. Median overall survival, 24.3 months. And the duration of response, median, was not reached. So when you look at overall for the whole group of patients across all tumors, you can see that the tumor mutational burden, when it's high, the 102 patients that had a high TMB actually had an objective response rate of 29%. And those patients who were high TMB but not high for microsatellite instability, because what they're trying to show is the outcomes just for the TMB group, 28%. So actually the TMB is a very meaningful measure because it highlights patients who are likely to benefit from this pembrolizumab immunotherapy. When you look at the patients who didn't have high TMB, you can see the objective response rate was only 6%. So this is another marker, again, through next generation sequencing. If we do this measurement called tumor mutational burden, or if we do this microsatellite instability assessment, these can identify additional patients who may qualify for immunotherapy, in this case with pembrolizumab, but there are also other therapies available, but they don't have the FDA approval for this particular indication as just yet. So I'm going to switch gears now and talk a little bit just about the tests that Tempus offers. Tempus Labs is a laboratory based in Chicago. We actually offer quite a number of molecular tests today to cancer patients. And we consider this a comprehensive genomic assessment because, you know, when we talk about assessing the patient's genetic profile, there's really a lot of different types of profiles to look at. So the main test that we offer for cancer patients using the tumor tissue is the solid tumor XT test. That's the one represented in the blue circle at the top. And that assesses 648 genes. And that is really kind of the main test that we have being utilized for most of these cases. Most oncologists and guidelines still say that tumor tissue is still the gold standard for cancer tissue assessment. Yes, there are also good reasons to use a liquid biopsy blood test, but because that is still, we still have problems with some sensitivity issues. In other words, for every liquid biopsy test, you may or may not find that every tumor sheds circulating tumor DNA. It's always best to actually go with the solid tumor test first. But if the solid tumor test fails, you would then quickly need to reflex to a liquid biopsy test. And that's the one down at the bottom, where we call that an XF assay. And here, currently, we offer a 105 gene assessment. Again, next generation sequencing, which include all of the key gene alterations that are actionable and druggable across various solid tumors. There's another test called the hereditary cancer panel germline testing called XG, circled in blue at the top. That is a separate, different test that is more assessing a patient's germline, meaning that they were the kinds of mutations that they might have been born with. You know, we all have mutations that we're born with. It's just a part of our own genome. And yet it's important to be able to differentiate what is actually coming from a patient's tumor and what is actually coming from the patient's background inherited germline. And when we actually do our XT test, we actually subtract out or correct for the finding of what might be in the germline. We call that a tumor normal matched testing approach, and I'll show you a slide on that shortly. The other kinds of tests that are mentioned around here are additional tests. I won't get into them in detail because I think it really represents a lot of other additional nuances and utilities across a variety of different tumor types. But I'll just call out one of them, which is called tumor origin, because that is oftentimes an important test for patients, specifically with cholangiocarcinoma. So just bear in mind that the diagnosis of cholangiocarcinoma on that initial biopsy, patients often are found to have a cancer in their liver if they're intrahepatic. They have a needle biopsy, and it might just come back an adenocarcinoma. An adenocarcinoma could be a cholangiocarcinoma, but it could also be, you know, from a different organ, like a pancreatic cancer or from a colon cancer. These are oftentimes difficult to tell apart just by looking at the pathology. Where is this tumor coming from? Where do we think it is a cholangiocarcinoma, or do we think it's something else? And historically, patients have had to just basically had ruled out. So, you know, you do a colonoscopy to make sure it's not a colon cancer, and you can do an upper gastrointestinal endoscopy to make sure it's not a gastric cancer origin, and full body scanning to make sure it's not coming from some other organ. So really, this TO test is an add-on. So when a doctor orders the XT next generation sequencing, they can opt to check this box that says, oh, I'd like to kind of assess what the tumor origin is. And what we're doing there is we use the RNA. So, you know, typically our tumor test is DNA, but we'll use the RNA that can actually give clues as to what might this tumor be coming from, because we've profiled so many cancers that they all kind of have a different sort of signature with the RNA, and that gives us some clues. And then the physician can get a report saying, oh, this is, you know, we think this is most likely to be, you know, this kind of cancer. So this could be potentially useful for cholangiocarcinoma patients. This is a busy slide, and I apologize, but I think the point I want to make is that you know, you'll notice that our XT test includes both DNA and RNA. And the RNA, you know, why are we doing that? Why is this important? Well, you know, in addition to enabling some of the tests I mentioned earlier about like tumor origin, what's really fundamentally important is that as we're looking these days for fairly rare gene fusions in many diseases that are in fact the driver mutations that are targetable by certain drugs, it's important that we capture all the possible fusions that we can identify. And in fact, what we find is that DNA, while it's good, it doesn't identify all the gene fusions. In fact, what we find is that when you do RNA with DNA, you actually find some additional gene fusions that might have been missed by DNA alone. And here are two studies up at the top showing that when DNA and RNA are done together, in the first study, 15.5% of the time, one finds these gene fusions that are identifiable only by the RNA, not by the DNA. So they would have been missed if the RNA wasn't performed. On the second study, it was 10%, right? 10% of the patients are identified by RNA only with these gene fusions. And well, are these actionable and do they result in benefit when targeted? This table down at the bottom suggests that in this study from Memorial Sloan Kettering, you can see that there were 36 patients who were positive by these fusions, and 10 of these patients actually received clinical benefit from the targeted therapy that was indicated. You can see that these are the different gene fusions, and these were the drugs that patients received, and the results, stable disease or partial response. So I think that's really emphasizing the importance of doing a complete job of capturing all these gene fusions. The graphic to the right just represents kind of a schematic showing why sometimes DNA fails to capture some of these gene fusions, and why RNA is more easy to detect, because it's actually, I think about DNA as it's a little bit like computer code. Computer code may be there, but it doesn't necessarily mean that there's something being acted upon that computer code. What the RNA suggests is actually something has been transcribed already. So it's more suggestive of a dynamic kind of code that's acted upon because it's produced an RNA transcript. So anyway, it's easier to find these fusions by RNA when combined with DNA. I also mentioned the importance of a tumor normal matched sequencing. Why do we do this? Because if you take a look at this human figure, we all have mutations in our germlines. We were born with these mutations. They are carried on from generation to generation, and they are known. So a good way to think about mutations is maybe it's like a typo error in the DNA sequencing. And so this letter A represents a germline mutation that this patient has. But when you actually submit a tumor sample, you'll find that germline mutation in the tumor sample as well, because the tumor actually originated from the patient, and every cell in the patient's body has this germline mutation, as well as the tumor cell. But the tumor cell also has this somatic mutation. That's what we mean by somatic. It's in the tumor. So when you do the tumor tissue sequencing, if all you're getting is the tumor tissue sequencing, you're going to find this abnormal letter A and the abnormal letter T. And you won't necessarily know, well, are these both coming from the cancer cell, or is one of them, or either of them really a somatic mutation, which is really kind of what we think about when we're doing sequencing of the tumor tissue. You'd want to be able to know, oh, well, we know that one of these is actually coming from the patient's germline. It's in the blood. And so we can actually do both of these. When we do paired tumor normal matched sequencing, we can actually more accurately call what's coming from the germline, what's coming from the somatic tumor, and then report out on what's coming out from the somatic tumor. The other thing that is a benefit of this is that when we do this sort of tumor normal match sequencing, is that if you know that something's coming from the germline, you might actually find that, wait a minute, there's actually a signal here that this patient may actually be carrying a gene in the germline that maybe other family members may have too, that could imply that there's a need for some family counseling and sequencing as well, just so that, if you're carrying a gene that is carrying a risk of breast cancer or colon cancer or other cancers, it's actually an important cancer risk syndrome to know about, because patients can be correctly counseled and tested and followed up accordingly. And this just shows, we did some studying on our own database. The cancer types down at the bottom, breast, pancreas, prostate gland, and ovarian, these are cancers today that have guidelines that say patients should be screened for possible germline findings if you have a cancer such as one of these, because it might carry some family risks that the whole family may need to be informed, addressed, and counseled and sequenced potentially. And you can see that the rate of these finding these different germline syndromes cancer syndromes is, on the order of 8 to 12 or 14%. But notice that the other cancer types, bladder, brain, lung, esophagus, cholangiocarcinoma is one of them, and head and neck are other cancer types that we found in our database that when patients have their sequencing, we find incidental indications that there may be hereditary cancer risk syndromes on the order of 4 to 7%, 8%. These are still sizable, and this really speaks to the potential need for physicians to be aware that, when you see a person with a cholangiocarcinoma, maybe this is, if you find this in the germline, maybe other family members too may need some testing. So overall, as I talk about, the tests we offer, Tempus Labs is really more than a molecular lab itself, because really Tempus is more interested as well in aggregating all of this data, not just the molecular data, but also clinical data and data from other sources in the care process, such as imaging data from radiographs or pathology imaging data from the slides of tumor tissues. This then contributes to a very, very, very large Tempus library of data that could then be the source of further machine learning and artificial intelligence. And this then becomes very valuable information to improve the entire field of oncology. We have to really be able to aggregate this information because there are so many patients who have rarer cancers, who have really individual circumstances that really, I think it goes beyond the ability for any one institution or any group of physicians to be able to kind of derive meaning from. You only can see this if you have larger and larger data sets. Artificial intelligence is kind of all around us today. We rely on it every day with our phones, and to tell us which road to take during rush hour. I mean, these are all things that are representations of where, in an information age and at a time with this kind of advanced computing, we should apply that technology to help patients, to help cancer patients be able to receive better care by being able to identify these patterns that are not otherwise accessible just by our smaller data sets and by human endeavors. I think we really do want to leverage this. And this is kind of what Tempus is all about, in trying to inform multiple entities, clinicians, pharmaceutical companies, to design better studies, to develop drugs faster and better, payers, biotech companies, and researchers. So this is really our objective for the company. And an example of, just a small example of one thing that we are doing that's quite innovative is actually enhancing the opportunity to enroll more patients into clinical trials based on the molecular findings that are matched to a particular drug. Many drug trials today are actually drug trials for, just like the one that I showed you, where we're looking for patients with a very specific gene alteration. They're so difficult to find, but if you're looking nationwide across large databases, they're much easier to find. And if we can identify these patients quickly by enrolling physician sites who agree to sign up and engage with us, to utilize our platforms, as we've done here with many different provider networks and research institutions. We have over 1,500 participating oncologists now that participate in this time trial network. And we've seen over 5,000 patients identified for potential enrollment. Now, these are all, I think, representations of advancement where we can really give back to the healthcare system and to make sure that these technologies are leveraged for patient benefits. I'll end up with coming back full circle to this case. And I really felt that this was a meaningful case that illustrated how important it is for patients to remain engaged and to really take advantage of clinical trials from testing. But I was particularly moved by the final few paragraphs in this case study. In fact, this patient was somebody who participated and became a patient advocate for the Cholangiocarcinoma Foundation. I really think that this is such a meaningful case because, as patients go through treatments and therapies themselves, they're also potentially able to help future generations of patients. And because the advancements are happening so fast in this field, I think it's especially important nowadays to be helping other patients and families to be educated about the options. In this case, the patient did opt for a clinical trial. That clinical trial did enable her to receive a therapy to be disease-free for a little over 7 months. And it does mention that, in that 7-month period of time, she was able to, she was unfortunately a young mother who had been married for just 6 years and had an 18-month-old son. She ended up actually being able to see through her son attending kindergarten. And there were a lot of, I think, meaningful time points where the patient was able to spend time with her family. And really, it is something that I think really encourages us to do everything we can to continue to find the right treatments for the right patients and to really continue to encourage other patients to do the same. So I'll end with that and want to thank you again for this opportunity.
Thank you. That was very good. And thank you for presenting on Sarah's case. A lot of us knew her very well. Yeah. Okay, we do have a couple questions. So I'm going to get to those real quick. And this is the first one is a really good question. So a wife got diagnosed with advanced IHCC and 2 satellites 3 weeks after the birth of their daughter. One tumor is 22 centimeters, one is 11, one is 9. The tumor analysis on tumor 1 has an IDH1 mutation. So is it recommended to test tumor 2 and 3 separately to see if there are other targetable mutations? And is it possible to treat them at the same time if they show different mutations?
Yeah, so I think that in general, many of these mutations that are the driver mutations tend to be mutually exclusive. They tend to be. So I think if you have one, it's very likely that would be the important driver mutation to target and to treat. There is, I would say at this point, not enough known about specific cases like this, where, there certainly is an opportunity, for example, to do a liquid biopsy that could, the advantage of liquid biopsy is that it is not specific to a specific biopsy location, right? So it's representing the ctDNA, the circulating tumor DNA in the blood is kind of an aggregate of all the patient's tumor lesions potentially that are shedding. Now, that could be something that could be useful, and we do know that sometimes, and this is, I'm citing more of the lung cancer literature, that a tumor sequencing assessment and a liquid blood sequencing assessment, they're not going to be exactly the same. In fact, we expect to be there's some concordance, but there could also be some discordance. In other words, you might find some things in the blood that aren't in the tumor tissue. And so I think that this is something that is still in its early stages, and lung cancer is now encouraged to actually do what they call concurrent testing because of that knowledge of discordance.
That's what I was just going to ask. I mean, is there a reason to have them done at the same time?
Well, I think in lung cancer, the literature suggests that yes, there could be good reason to do this. And in fact, it was just about 3 or 4 weeks ago when the IASLC, the lung cancer guidelines, came out and made such a statement that there is a good reason to pursue concurrent liquid and tumor tissue testing at the same time. In cholangiocarcinoma, we don't have that yet. And, it's harder to get this kind of data because I think it's a rare tumor type. But, I would say, having the IDH1, I mean, again, please keep in mind that I'm not giving medical advice here, so I'm not in a position to do that. But, I think that, this is definitely a targetable alteration. And in general, when we talk about the concept of having driver gene mutations that are driving that tumor, typically we're talking about significant drivers that kind of preclude the finding of another driver.
So that brings me to my next question that gets asked quite often is, how often should the testing be repeated, or should it be repeated?
You mean after patients
Progress
take
or
a therapy and progress?
Yeah.
That's a good question. I mean, I think, again, I'm going to cite the lung cancer literature again, where, in lung cancer, I think there's actually very good, well-documented use cases where when one receives a particular, in this case, it's an EGFR inhibitor called osimertinib, this osimertinib has now become first line for patients with those EGFR mutations. And one can potentially do a subsequent liquid biopsy at the time of progression to look for specific mechanisms of resistance. And in fact, I mean, this is commonly done in research. I mean, I think there's good reason to believe that indeed, by doing another liquid biopsy in a longitudinal fashion as patients continue to be followed over time, we do know that in general, the circulating tumor DNA will rise and in counts in variant allele fractions for that particular marker when therapies are no longer working to control it. They also go down when the patients are responding to the therapies. But again, I think this is something where we don't have a lot of data in cholangiocarcinoma yet. And I think, again, we're just paralleling what we see from other cancers.
Okay. Another question is, what is the level you look for high tumor mutational burden? I know, like on MSI, it usually states stable or high, and but how do you know what is high TMB?
Yeah, TMB, tumor mutational burden, is just a calculation. It's a continuous measure, right? So it's basically a ratio of the mutations per megabase sequenced. You have to have a sizable, larger enough panel to do that. There's recently been a lot of focus on the different types of variables that can feed into how TMB is measured. Depending on what is actually sequenced, what genes are included in the sequencing. There's also, I mentioned the tumor normal match. I mean, there's the potential contribution of germline findings. Ultimately, I think in this recent paper that came out from this Friends of Cancer Research, they did indicate that indeed they feel that it is important to account for what the germline may be contributing, because it's really more the tumor's mutational burden that you're mostly interested in. So I think that accounting for that tumor normal matched measurement is potentially important, but it is in general a continuum. The cut point of 10 that you've seen is a cut point. Obviously that keynote trial that resulted in pembrolizumab's approval was based upon that FDA submission and approval. But I think in general, it's acknowledged that there isn't one hard and fast cut point that is black and white, separating the population into ones that do respond or don't respond to pembrolizumab. But it is a continuum. So that's where I think a physician looking at tumor mutational burden should look at the number and look at the context, what test was used, what is the circumstance, and make a clinical judgment. I think anytime you take any biomarker and say this is yes or no, black and white, one has to be a little bit careful about over interpreting them. If you're 10.1 or 9.9, I don't think that's that much of a difference.
Okay. Our test also available in Europe. And I guess we should ask, these tests have to be ordered by a physician, correct?
Yes, it has to be ordered by a physician. Right now in Europe, I mean, we have some usage of the test, but it's mainly represented through distributors that we have. I know we have a large group of physicians in Israel who are using the test. It is something that we are actively looking at to broaden our presence internationally. But it is something I know that we've had some usage in both Asia and Europe and Israel.
Okay, and then the other part of that question is, can the FDA approve to be prescribed to patients in Europe? But I'm going to say it has to be approved by the EMA, right? The European Medical Affairs team that approves drugs over there.
Right. I'm not going to speak to the regulatory environment there, but yeah, I think it's something that we would need to address. Yes.
All right. And this is a clinical trial question as well. Can you enroll in the USA if you're not a US citizen? And I think every trial is different, and you'd have to call the information on the clinical trial website, I think, unless you know different. And then is there a reason to believe that first-line therapies with the gemcitabine and cisplatin will get replaced by these newfound inhibitors for mutations?
Well, I think that the drug companies are actively looking at first-line treatments. So typically when drugs are first developed, they have to pursue the standard of care, and then the experimental treatments are tested. And that's exactly what they've done. So it wouldn't be surprising to me that for these to move into the first line at some point.
Yeah, they're definitely in a trial right now. And then the last one is blood biopsy has not shown my FGFR2 fusion. Is this different depending on the test used?
Well, if it's a blood biopsy, potentially, I think you'd want to see if a tissue biopsy can be done, if at all. Again, it just depends on the specifications of that lab's ability to detect. Gene fusions are relatively rare finds, and technically, not always so easy. And so I think what I spoke to earlier was, the importance of tissue-based DNA and RNA.
Okay. Can GemCis first line be combined with inhibitor therapies? I think that depends on the doctor and if they will prescribe it that way.
Yeah, I mean, at this point, I think if you're going to go with what's on label, that is not the method of using these drugs.
Right. I think there's a lot of trials with that going on, so we'll see what happens through that as well. And that was the last question, and that was a great presentation. We thank you so much for taking the time to share with us, and we appreciate it. And thank you everyone for their questions, and thanks for joining us today. Have a great day.
Thank you so much. Thank you very much.
You're welcome. Bye-bye.
Bye-bye.